Today we are going to discuss woman complaints of reducible vaginal swelling. After shaking the hand of the patient and introducing yourself, you are going to start to take the information about the patient's name, how old is she, and what is her nationality, and her social status, married, divorced, or widow, and if she has any pregnancy before, we are going to determine the outcome, and then we are going to determine the method of contraception if she was using, and what is her blood group, and what is the RH typing, and what is her job, and where she lives, and in special habits: smoker, alcohol addict, narcotics or addict narcotics, smoker and alcohol addict, smoker and narcotic addict, or smoker non-narcotic addict, if she is smoking or not, and how many cigarettes per day, and for how many years she is smoking. And then what is the main complaint of the patient? The patient would complain that she has feeling of swelling coming from the vagina. Onset of this swelling, when she notices this, is after delivery or after cessation of period, or since weeks or months or years. And this swelling, she noticed it is accidental or insidious or sudden or gradual onset. This swelling, once she discovers, will not change or increase in size or decrease at night. This swelling, bulge of anterior vaginal wall during straining, or bulge of posterior vaginal wall during straining, or descent of the cervix during straining, or bulge of both vaginal wall during straining, or cervix is outside the vagina. Reducible vaginal swelling during straining, or reducible vaginal swelling by a hand and on bed lying, reducible vaginal swelling only by hand. It appears during straining and disappears once stop straining, or appears during straining and disappears at night or by pushing by hand. It is present all the time but can disappear by hand pushing. It appears all the time but can be reduced by pushing. If there is abdominal pain, on the onset of the pain, sudden, gradual, and chronic. No abdominal pain or pain precedes the appearance of the swelling, or long-term pain but increased partly after appearance of the swelling, or the pain and swelling appear on the same day. This pain is dull aching or heaviness or dragging pain. Pain during period or no pain during period, or the pain has no relation to the period. There is backache, or backache related to the lower limb. As usually, we ask about the menstrual history, the age of menarche, and then last menstrual date, and the cycle is regular or irregular. If the cycle is regular, we are going to determine the length of the previous length of the cycle, and the period for how many days, and the amount of menstruations, how many napkins per day, and if there is pain in relation to the period. Colic pain first day, nausea and vomiting, or severe colic pain, nausea, vomiting at bedtime, pain for 2 days, pain all the time of the period, pain before and all period times. Pain start before period and increase during period and last for a few days after period. If the cycle is irregular, we determine if she has a length of the cycle, if months or more than 6 months, and duration of the period, how many days, and how many napkins she is using, and having a bleeding, stained or soiled or soaked or blood clots, and those will change, or the hershey's or there's milk discharge in the breast. If the patient has anemia or not, she has dizziness, fatigue, dizziness, and dyspnea. If the patient has stop of the menstruation due to aging, menopause, when is the last period, at what age, and there's hot flushes, or finished, there's abdominal bloating, vaginal dryness. We'll ask the patient she has vaginal discharge or not. No vaginal discharge or increased mucus discharge 5 days after period, and some days or water discharge. What is the color of the discharge if she has? Yellow, colorless, green, brownish, bloody. And the vaginal discharge has changed its color or not. And the consistency of discharge is watery, fluid, mucus, mucopurulent, milk curds, blood tissue. And what is the amount of the discharge is minimal or excessive. If this discharge has smell or not, offensive or very offensive. There's itching or burning or soreness. If she has any discomfort during sexual intercourse, superficial dyspareunia, deep dyspareunia, or sexual unsatisfaction, widening of the vagina. Then we will ask about the urinary symptoms, the increase in frequency or not. During the urination, she has to push the vaginal wall in order to complete emptying of the urine, or there is sensation of incomplete emptying and return shortly after passing urine. There is urgency and burning and dysuria or burning. And there's continent all the time, or the stress incontinence, urine escape zone during coughing or laughing. Well, I'm going to ask about bowel symptoms. There's constipation or no constipation, feeling of incomplete emptying, or has sensation of complete emptying or normal. Sometimes there's pelvic congestion symptoms. There's pain during period and vaginal discharge and dyspareunia, or pain during period and vaginal discharge, or pain during period and dyspareunia, pain during period, vaginal discharge, heavy period, dyspareunia, or pain during period and heavy period, or heavy period and backache. Then we will analyze the past obstetric history, each pregnancy at which date, and the duration of the pregnancy, and any problems during pregnancy, or the end of pregnancy, abortion, delivery, or if delivery, spontaneous, vaginal, breech, forceps, section, and then newborn, male or female, and what is the weight, any postpartum complications, and any neonatal complications, and the patient is breastfeeding or not, and for how long. So the people, there's prolonged labor or forces of induced delivery or deliver in squatting position or abdominal pressure during second stage or Kiddie's method to deliver the retained placenta. There is perineal tear, sutured or neglected perineal tear, and the perineum or rest or early ambulation or carry heavy objects. What is the work of patient? Daily or home activity, carrying heavy objects. The weight of the patient, she is increased weight after marriage or average weight or reducing weight. And past medical history of asthmatic bronchitis, chronic constipation, hepatomegaly, or no medical problems. Then we are going to shift for the examinations. We assess the general condition of the patient, normal death neck or the weight of the patient. She is normal, obese, or morbid obesity, and we examine the chest that's normal, or there's wheeze or wheeze crepitation due as chronic asthmatic bronchitis infections. We examine the abdomen. There is no abnormality detected, or there is ascites, or there is ovarian swelling, or uterine fibroid, hepatomegaly, or hepatosplenomegaly. And then we go to examine the vaginal examination, inspection, discharge. There is no discharge, white milk cards, cantilever, offensive discharge, yellow discharge, purulent discharge, mucus discharge, mucopurulent discharge. Then we ask the patient to cough in order to see the escape urine during cough, stress urinary incontinence or not. And then the vulvar skin is no apparent lesions or scratching marks. And we look for the introitus in the patient strain, the descent of the anterior vaginal wall and straining cystocele, or descent of posterior vaginal wall and straining rectocele, descent of anterior and posterior vaginal wall and straining cystocele, and descent of the cervix during straining, first degree uterine prolapse, second degree uterine cervix comes out of the vagina, third degree uterine prolapse, the whole uterus is outside the vagina, uterine prolapse with decutaneous ulcers and the vaginal wall that bleeds on. We do this with the prolapse and then ask the patient to cough. No escape of urine or the escape of urine. So when we reduce the prolapse and the patient has stress urinary incontinence and that was not apparent before reduction of the prolapse, so the patient has hidden stress urinary incontinence in association with the prolapse. We differentiate between second and third degree of uterine prolapse. Second degree uterine prolapse, the uterus is felt between the fingers at anteroitus. The fingers and third degree uterine prolapse, the fingers above the uterus in the anteroitus. Then we test the look for the vaginal discharge not, and then we test the levator-ulnar muscle to all the prolapsed parts are placed within the pelvis, and then we introduce two fingers inserted in the sides of the vagina, and we ask the patient to close her vagina against the examining fingers. And then we do speculum examinations. See the discharge of mucus, mucopurulent or bloody, frank blood. Or this normal cervix or cervical origin, cervical ectropion or nepotian follicles. We examine digital examinations. Cervix is firm and or there's tenderness moving the cervix, and Douglas pouch is free or uterus is felt in case third degree uterine prolapse. By manual examinations, the uterus size normal or not or asymmetrically enlarged. Then by manual examination of the adnexa is normal, or there's tenderness on one of the adnexa, or there's ovarian cyst, or there's ovarian swelling. This patient has rectocele, this patient has cystocele, this is cystocele, this is vaginal fold, prolapse. Thank you.